Good afternoon, and welcome everyone to this MindSite News live event, The Return of Trump, What Does It Mean for Mental Health Policy and Advocacy? I'm Rob Waters, and I'm the founding editor of MindSite News. For those of you just learning about MindSite News, we are the nation's only news site exclusively dedicated to reporting on mental health and the broad array of issues that intersect with our mental health. We are nonprofit, and you can sign up for our daily newsletter and/or make a donation by visiting us at MindSite News. That's MindSitenews.org. You'll find tabs at the top of our website to subscribe and donate. At the end of the event today, we'll open up for questions, and we'll ask folks to please use the Q&A function on the bottom of your Zoom screen to send your questions. We'll also be sending the recording to everyone who has signed up and registered for the event. And now on with the event. We are, to say the least, at an interesting time in our history. In terms of mental health, we are not far removed from a pandemic that both amplified and brought to stark public attention the dysfunction and failings of our mental health system. We also are coming to the end of an administration that devoted more attention and resources to mental health than any before it. The Department of Labor has led a process tightening up on health insurance enforcement and wrote new regulations for ensuring parity in mental health coverage that should go into effect soon if they aren't blocked by Congress. The Department of Justice has investigated the police departments of numerous cities, partly for shooting people suffering from mental health crises. Some of those DOJ investigations led to consent decrees that required cities to implement crisis response services that don't rely on police. And Congress, while gridlocked on most policy issues, has passed legislation funding the 988 hotline to the tune of more than $500 million a year the last 2 years. It expanded temporarily support for school mental health. It boosted the number of community behavioral health centers, and more. And yet, in many respects, little on the ground has changed. Opioid overdoses surged over the past 4 years, finally coming down a bit last year, but still claiming nearly twice the number of lives every year than we lost during the Vietnam War. It remains incredibly difficult for many insured people to get their health insurers to cover the mental health services they need. Large numbers of people with severe mental illness continue to suffer visibly on the street. Now again comes Trump, bringing as abrupt a shift in administrations and philosophies as we've seen since, well, 2016. So, what does that mean for mental health? Well, the relative level of bipartisanship that we've seen around mental health continue under Trump and the new Republican Congress. So many questions. Will changes to Medicaid, the biggest payer of U.S. mental health services, take away people's insurance or reduce their access to care? Will those federal parity rules go into effect and get enforced? Will mass deportation threats announced by Trump and his border czar be carried out? And what kind of effects are they having on the mental health of immigrants and families? Will Trump's call to bring back mental institutions and round up quote unquote deranged people on the streets actually transpire? Will states take a bigger role in creating new services and policies, shifting the action away from Washington? And one question I might add after yesterday's chaos in Washington, does Speaker Mike Johnson have a good therapist? These are some of the issues we're going to discuss today with a panel of amazing experts and advocates. Joining me today is Tom Insel, a psychiatrist and neuroscientist, former director of the National Institute of Mental Health, and a founder of numerous companies, including Vana Health, where he serves as board chair. Tom has also been a mental health advisor to the governors of California and New York. Aimee Hilado is an assistant professor at the University of Chicago Crown Family School of Social Work and the chair of the Illinois Coalition for Immigrant Mental Health. Her research focuses on immigrant and refugee mental health and workforce development. She and her team developed the Rapid Response Mental Health Initiative supporting the 50,000 plus asylum seeking migrants who have resettled in Chicago, training nearly 700 non-clinical frontline providers to be part of the city's mental health care plan. Luke Sikinyi is a mental health advocate who was drawn into the field after struggling with his own mental health challenges and working in direct services. He is Director of Public Policy and Public Engagement at the Alliance for Rights and Recovery. He pushes for system reforms, peer services, and the protection of rights for people with mental health challenges. Tim Clement is the Vice President of Federal Government Affairs at Mental Health America. He has worked in behavioral health policy and advocacy for the past decade and has written dozens of state and federal laws about mental health insurance coverage, including the amendment to the federal parity law in 2020, which, I might add, was signed by then President Trump at the end of his first administration. Rebecca Bagley is President and CEO of the Kennedy Forum, a national advocacy organization founded by Patrick Kennedy that seeks systemic transformation for mental health and substance use prevention, treatment, and care. Bagley oversees the forum's effort to expand the reach of promising practices in mental health policy, workplace mental health, school-based mental health, and healthcare integration. So that is our distinguished team for today. So welcome, everybody. Thanks so much for joining us. And maybe let's start with a big picture overview of where we've come from and where things may go. Tom, would you like to start us off?
Yeah, I'd be happy to. And I'll start by thanking you, Rob, and the MindSite team for bringing us together. It's the right time to have this conversation. There's a lot we don't know, obviously. And so much of this will be sort of hypothetical, but it's still worth thinking about what the possibilities are. As I think about this, I've been through this a few times. I've seen changes in administrations that lead to changes in directions. And I think it's kind of, if you don't mind me taking a minute, let's put this into sort of a historical context because there is some value in that. The tradition in the United States has been that basically nobody wants to pay for mental health care. It was paid for by the states through the state asylum system from about 1850 to the first Kennedy administration in 1963, when JFK put in the Community Mental Health Act. That was the first time, really, that this idea that the federal government would have a role in mental health became reality. And over a course of a couple of decades, we had federally funded clinics and federally funded programs that was going to be expanded by Carter. And then when Reagan came in with this idea that government was the problem, not the solution, it was kind of like the hot potato that nobody wanted to handle. So it went mental health care, and the entire community mental health system got moved into block grants. And it was really the states that then were responsible once again for the care. They obviously didn't have the budgets that they had 30 years before. They had moved on to criminal justice and other areas. And so, not surprisingly, that gave rise to much of what we see as the disaster for mental health care, particularly for people with serious mental illness through the 90s, early 2000s, until really the last 3, 4, 5 years, when once again the hot potato has been passed back to the federal government. The federal government has leaned in to say, no, this isn't working and we need to do more, whether it's crisis services or CCBHCs or parity on all of those issues you mentioned, Rob. And it's been kind of stunning. I think Biden was the first president in 60 years to talk about mental health in a State of the Union message. Pretty awesome to hear that. There's just a lot of leaning in. The Office of Domestic Policy really took this on. And to be fair, I think, really it was also leadership in Congress that really mattered, and it started to float this issue to the national consciousness with a series of hearings and congressional actions. At a time when the country became more polarized and became really caught up in all sorts of culture wars, this was one of the very rare issues that did really stay bipartisan. And some of the most effective legislation came out of the most conservative Republican leadership. It was pretty stunning. important to recognize that. I think that's, an important insight that we need to talk about today. Obviously, as you said, we're in interesting times. That hot potato is getting passed again, almost for certain. One of the things that will change is that the states will have to take on more of a role, and it seems like pretty likely that both the executive branch and the Congress at this point are going to be backing away from having the federal government lean in on so many issues. I think just to round this up, it's important to remember that in spite of this whole hot potato story, the states have always really been the center of gravity for mental health care. And no matter what the federal government has done, we don't really have a federal mental health system. We have 50 state systems, and in California, we've got 58 county systems. So it's a very distributed network of care plans with not only different state systems, different state licensing boards, no federal licensing board. And we've got basically every state having a different Medicaid program, which is really key. For me, the federal government matters, and it matters a lot in what I call the 3 Rs. So it's the federal government only that is the source for research, at least for government-funded research, whether it's through the VA or through the NIH, easily $4 billion, maybe $5 billion a year, going to developing the new treatments, new diagnostics, new care plans, all of that. So that's the first R. The second R is regulation. So you need to have an FDA that determines whether new treatments are actually effective and safe, and nobody else does that. And so that's something you do not want to gut. And then the third R is reimbursement. And well, I said that, the states have the systems. It's, most of the money is coming still through Medicaid, Medicare, VA together, largest payers for mental health care in America. That's not true for other forms of health care, but for mental health care, it really is public payment that matters. And so the policies around that payment really matter. And while it's true that states will submit waivers to get certain things covered, it's the federal government that decides whether those waivers get passed or not and how things get paid for. And so that's the conversation we need to have. And we've got some great experts on this call to talk about what happens when politics does invade those reimbursement decisions, and how does that begin to change everything from what's paid for, how it's paid for, when it's paid for, who actually can get paid for providing mental health care. So I think these things are really, really incredibly important for us to think about. I mean, none of us can guess what's going to happen in the next 4 years. But as we start this conversation, if I could just say one last thing, which is, I don't think anybody is totally satisfied with where we are today. And in spite of whatever the executive branch, the legislative branch, all the people that you mentioned, Rob, have done to try to make things better, they are still unacceptably bad. We do need disruption, and we do need innovation, and we do need leadership here. And so if the hot potato moves to the states, we're going to be looking maybe in a new direction for this to happen. But I do think we have to, at the same time, we have anxiety about what may be coming. I think we should be realistic that what we're still living with is not where we need to be. So I'll stop there. Sorry for the long monologue, but I wanted to sort of put some framing issues in here.
No, I think that's great, and thanks for setting things up in that way. I think maybe the first thing to talk about is that last R, and reimbursement, and let's look a little bit at health insurance, and where that's going to go. Most people seem to think that Trump and Republicans in Congress will not repeat the failed effort to repeal the Affordable Care Act, but there are proposals out there that could knock people off Medicaid and reduce subsidies that help people buy their insurance on the ACA exchanges. Tim, can you tell us about some of the potential threats to Medicaid and what they could do and how they could materialize?
Well, yeah, sure. And so one thing I think we're pretty certain to see are work requirements imposed on Medicaid. And during the first Trump administration, since the first Trump administration, 13 states have tried to implement, have filed waivers to implement work requirements with, most of them getting blocked in court. One of them in Arkansas actually went through in 2018. It was only in effect for about 9 months, but what it did is it resulted in 18,000 people being kicked off of Medicaid. That might not sound like a lot, but there's only 850,000 people on Medicaid in all of Arkansas. Anyways, that's 2% of the Medicaid population being kicked off in 9 months. So,
And just to clarify, that those Medicaid work requirements say that in order to continue receiving Medicaid, people between 19 and 49, I think it was in the case of Arkansas, have to meet have to do work, be employed, or do community volunteer work.
That's correct. And if they don't do that, or if they just don't get the paperwork filled out properly, then they're disenrolled from Medicaid. And so the Congressional Budget Office estimated that if we were to see work requirements put in place in statute, it would save $100 billion over 10 years, which is one reason that Republicans have eyed it in connection with their tax cut proposals. And it would kick off about 650,000 people from Medicaid throughout the country. So this is definitely something I think it's very likely we're going to see that at least introduced and bandied about. And there's a decent chance we'll see that actually enacted as part of a reconciliation bill, depending on how that's chunked up, as if it's one big reconciliation bill or they break it into two. But I do think it's pretty likely we'll see work requirements put out there. One other thing that would be actually much, much, much more drastic would be, which I don't think we're going to see, but it has been discussed publicly by certain key committee chairs and others, is converting the entire Medicaid program into a block grant. So Dr. Insel just mentioned block grants in the Reagan administration, community mental health. The way Medicaid is currently structured is an open-ended, as some people call it, entitlement program, where the federal government, they pay a certain percentage of each state's Medicaid expenditures, but whatever the overall expenditure is, the federal government will pay that amount. So if they have to spend, so in some states that's 50% what the federal government pays. In other states, it goes all the way up to 83%, depending on the state's wealth. So in a state like New York, it's 50%. So if Medicaid spending in New York is $78 billion, the federal government's going to pay $39 billion. If it's $84 billion, they're going to pay $42 billion. But what a block grant does is it's a fixed amount of money that's subject to annual appropriations by Congress. And so it's the service. So no matter what the actual costs and need might be in the state, with the block grant, the federal government can only spend up to that cap. And so what block grants do, in theory, you could increase the appropriations for those block grants commensurate with inflation and so forth. But the history of block grants, particularly over the last 40 plus years, since the ones that Dr. Insel mentioned, block grants never keep pace with inflation, and it always leads to cuts in people and reduced access. So that's something, if you were to see that would be a huge fundamental change to how Medicaid works. That was a key component of the repeal and replace effort of the Affordable Care Act back in 2017. We've heard this discussed. I do not think it's likely we'll see it actually even introduced, just because there's such a thin margin and it'd be very difficult for vulnerable members in swing districts. That would be a dramatic change to the Medicaid system that has been talked about publicly. So it is something just to flag for people that is out there.
And then I think also there's the issue of Congress reducing subsidies that help reduce costs to individuals who get their insurance through the ACA exchanges, and the reduction of those subsidies could also have an impact. Can you say a little bit more about that?
Absolutely, yeah. So as part of the Affordable Care Act passed in 2010, some people are eligible for premium tax credits that would help them offset, and they get it in advance, so they can use to pay for their premiums. It's not they don't get it when they pay their taxes. It's upfront when they buy their insurance. With the American Rescue Plan in 2021, and then the Inflation Reduction Act continued this. They were great enhancements to those premium tax credits, so that greatly reduced the cost of insurance for many people. In fact, for some people making between 100 and 150% of the federal poverty line, they actually pay $0 in premiums for their insurance. And so That's something that not only does that's greatly lowered costs, it's also created significant increase in individuals that are enrolled in the marketplace plans. The Congressional Budget Office similarly found that not only would costs go up significantly if these tax credits are not extended, and I should have mentioned that nothing has to happen necessarily. These tax credits, they expire at the end of 2025. So if nothing's done, then they certainly will go away. And so what the Congressional Budget Office has projected is that 3.8 million people will lose lose coverage if that does happen. So it's something that without anyone doing anything, you could see millions of people lose their insurance coverage and access to care.
Okay. All right, well, let's move on to another aspect of insurance, which is, we've just been talking about people's ability to have insurance. The parity requirements and the whole parity effort has been to get people who have insurance for their insurers to actually cover mental health and substance use services. And it's been it's a huge struggle for people to get those treatments covered. We know that there's incredible frustration around health insurance, and particularly around mental health. And we've seen that in this sort of social media posting around the murder of the United Healthcare CEO. People are not happy with their health insurers, and parity, mental health parity is one piece, or lack of parity is one piece of that. Um, so there's been a push to strengthen to require health insurers to cover mental health and substance use for many years. And in September, the final rules implementing and enforcing the Parity and Addiction Equity Act, Mental Health Parity and Addiction Equity Act, were finally released. So let's talk for a minute about what they do and about the potential for Congress to kill them using the Congressional Review Act. So I think this is, Tim and Rebecca, this is kind of probably your bailiwick. So either of you could go first.
Well, maybe I'll just kick it
Yeah,
off
go ahead.
and add a little more color. But obviously we, as the Kennedy Forum, it's been one of our big pushes since Patrick was the co-author of the Mental Health Parity and Addiction Equity Act in the original. And really, building those coalitions over time, even before that act was passed, to ensure that, mental health and substance use was on the agenda, that was nonpartisan, bipartisan, through that whole time. And really, again, you mentioned the 2020 amendment. It really has been just a nonpartisan issue. And I think, as you mentioned in your opening with COVID, really became like a public health issue that everybody recognized. And so it became a moment in time between the administration's interest, the public's interest, to be able to really um, shore up the rules around that Mental Health Parity and Addiction Equity Act. And so those came out. They clarified a lot of different issues that I think really help to ensure over time both access and payment. Of for individuals. That's one thing I think that we all think about all the time. Is this goes back, we'll talk a lot about policy and those things, but it really goes back to people, right? And like families, and we all have that connectivity to, something in our lives, whether it's us or a family member. And we've all had issues, getting things covered. And so it's such a real issue. I think that honestly, like, it only becomes partisan if we make it that way. We being advocates, we being the community. And so, things like transparency and data become extremely critical as we move forward in continuing to both enhance the system basically. And don't forget also that companies, the self-insured companies are really, they rely on the third-party administrators for the data and for execution of the plans. And so I think the companies are really stepping up in a way and recognizing the need, both not only from like a benefit standpoint, but also from a strategic workforce standpoint. This is going to be the issue going into the workforce. And so things like parity, I mean, that's what it's about, right? Is level setting, giving access and payment, ensuring that people can do their best, be their best, at work and in the structure of their families. So I just wanted to put it in that high level context because that's a nonpartisan issue and something that we should all be working on. And the how of that becomes obviously really important. And I think there's ways that we can work on that together.
Yeah, and I could
And
just, oh, I'm sorry, Rob, go ahead.
yeah, no, go ahead, Tim, please.
No, I can just add that I completely agree with Rebecca. Parity has been a nonpartisan, bipartisan issue since it's existed. That was very much reinforced over the last 7 or 8 years before Congress amended the law, and then President Trump signed that amendment in 2020. 20 states had passed very similar legislation. States as conservative as West Virginia, Oklahoma, and Kentucky, and to as liberal as Connecticut, Massachusetts, and New Jersey, passing the exact same legislation, which exactly matched what Congress passed. So we've really seen a lot of bipartisanship on parity. So while yes, the Congressional Review Act, that is in fact possible. Congressional Review Acts allow Congress with just a simple majority in the Senate. They don't need to get to that 60-vote threshold. They can overturn rules that were issued near the end of a presidential administration. The way how they count the days and how that happens is very complex, but anything issued after August, which these rules were, could be subject to congressional rule. So we can never rule anything out. You've seen the last 36 hours in Congress. You can especially say we definitely can't rule anything out on anything right now. But this hasn't, from what I can tell, this has not really been on the radar. So, and I think that we've seen also there was a big push over the last 18 months when the rules were first proposed in July from some opponents of the rules, and I think we might talk about that in a little bit, trying to very, very strenuously to drum up opposition among Republicans on Capitol Hill against the parity rules, against the parity enforcement, and it just didn't land. So I think that it's something, and that's because Republicans recognize this is mental health, substance use, that affects everyone. Rural America, cities, suburban America. It's something that Republicans think to themselves, look, this is something we support. Most of us voted for the amendment, so this is something that I don't know. Again, you can't rule out a Congressional Review Act, but I don't know that that's necessarily likely, but we'll see. We'll see what happens.
Okay. Another potential threat on the horizon to at least enforcement of the Parity Act, assuming it survives, is the Supreme Court's decision in overturning the Chevron Chevron deference. So the ruling the precedent had been that federal agencies broadly were seen as having the expertise to make decisions about how to implement rules, and there was a certain deference that the courts would show to them. That was kind of thrown out by the Loper Bright decision. So what threat does that pose to enforcement of parity rules moving forward?
You want to start, Tim?
Yeah, sure, absolutely. Thanks, Rebecca. Well, I'll say the first thing I'll say is I think it's pretty close to certain that we will see a challenge to the rules, and of course, and not necessarily because they're particularly vulnerable to them. The rules, of course, were written after that the Chevron deference was overturned. So the administration wrote them with that in mind, knowing that they would have to survive this new landscape. And I do think they hew very closely to the statutory language. That being said, we're in a new world. This is an incredibly complex statute, incredibly complex rules. So of course, this is going to be a good case study to see what happens. So I think we will see a challenge. And I think as to what that outcome might be, could it completely overturn the rules? Maybe. Could it completely affirm them? Maybe. Or can completely have very muddled outcomes that we can't possibly predict? I'd say that's also probably likely as well. So I think we don't know how that's going to play out right now. I don't think, as we've just said, there's no partisan lean to this law and the rules. So I do think that, if you do quote unquote judge shopping, where you look for judges that have certain tendencies, whether they be conservative, liberal, whatever it might be, I don't know you're going to necessarily know how one of those judges may rule, because this is, again, very complex and something that does not have a partisan distinction to it. So I think it's something that it could be very threatening to the rules, or it could not be at all. But I think it's something that any of our guesses is as good as anyone else's, because I just don't think we know right now.
Okay, great. All right, well, let's move on to another area. As a candidate, Donald Trump promised repeatedly, indeed, he made it the centerpiece of his campaign, to close the door to immigrants seeking entry or asylum into the US and to begin a program of mass deportation. His border czar went to Chicago and threatened to arrest the mayor, who, like a number of other mayors and governors, has vowed to protect undocumented immigrants who have no criminal records. And they've also pledged to refuse cooperation with immigration officers. MindSite News has been doing a lot of reporting on the mental health needs and challenges of immigrants in Chicago. We've gotten to know Aimee Hilado with the Coalition on Immigrant Mental Health. Aimee, some 50,000 migrants have been bused to Chicago from the border by Governor Abbott of Texas over the last couple of years. Tell us about the people who have come and their histories. And yeah, let's start there. Tell us about, I mean, who are the people and what have they been through on their journey to the US?
So, what I will say for the migrant arrivals, the immigrants coming to the US generally, the decision to leave their home country and make this journey to the United States is not something that they take lightly. When you speak to arrivals, they will tell you that they know the journey is going to be difficult. They know that there are potential risks. There is no guarantee of survival or a pathway to citizenship, and yet oftentimes they will also cite in the same breath that they have no choice if they want to live their lives with opportunity, with dignity, with safety. And so as I think about the arrivals coming to Chicago, oftentimes our minds go to large groups of Venezuelans, which is accurate. But when you drill down to the data that we have at the city level, there's such diversity in who are coming. Folks that are coming from the Congo, folks that are coming from China, folks that are coming from Haiti. And what my research team hears directly from those arrivals and from the workforce supporting them is that they talk about the constant fear throughout the journey, wondering whether that fear will subside now that they're here in the United States. They will often talk about grief and loss of support networks in their home country, and also witnessing loss of life in the journey to the US. And they've witnessed or maybe directly experienced incredible violence, physical, sexual violence, even at the hands of people they paid to help them to come to the US. And then the process of being bused to a new city. Some of them are learning for the very first time that they have shaky legal status. They don't have secure housing, access to care, access to a lot of the resources that they were looking at. And so that adds yet another layer of uncertainty and worry. And there's particular concerns for parents. There is this added layer of guilt and shame that they oftentimes will talk about. Parents will talk about wanting to give their children a better life, and yet they carry the pain of knowing that they expose their children to a level of fear and violence and loss that no child, no youth should have experienced. And so, to take a step back, what we know in research, what we know in practice is that the compounding effects of trauma and stress along the migration journey, and without access to appropriate mental health supports, it will impact their ability to adjust and to adapt to life in a new country.
And in Chicago and beyond, really, what is the community of mental health providers and advocates doing, to address these needs, to support the folks that have come? And what should people know, what should people in this audience know about these efforts and how, if they're concerned, can they get involved?
Yeah. I will say mental health providers and advocates have begun to be very clear and highlight, maybe shift the narrative of what we think mental health care is, that it's not just therapy alone and specialized care that you can access only at a hospital. I think the general environment, beyond addressing some of the trauma and stress that is experienced along the journey, resettling here in the United States and the rhetoric that you had mentioned is also pretty damaging. That when you have words that really villainize a certain community, it threatens that sense of security and safety and belonging. And that's a fundamental human need. We need to feel stable. We need to have peace of mind. And that is a critical component of mental wellness. And so as we are starting to see distress and we think about the continuum of care, we are getting reports in schools, in hospitals, and in community organizations about how do you respond to the threats that people are feeling compounded with that journey. And so you're seeing, going back to, well, what are mental health providers and advocates thinking about? What are we doing? We're starting to focus more on the continuum of care, focusing more on not just the intervention side of specialized care, but how do we put more weight around promotion of mental health and prevention of mental health crisis? I think that as a field, we're thinking about how to be more inclusive. And so who gets to be part of the mental health workforce? And to Dr. Insel's comments, it is so relevant. Who gets to define who the mental health provider is? Who gets to be paid? Who gets to bill? Bill is actually part of the conversation. And what we're arguing on the ground here in Chicago is we've got to train non-clinical frontline providers to be part of this larger plan. We need folks that are in schools, faith-based organizations, and community organizations to be trained on how to respond to trauma, to be able to promote adaptive coping, and then be able to field and narrow the number of folks that actually need care. Because we know in the state of Illinois, we know across the nation, we don't have enough inpatient psych beds for adults. We don't have enough for children and youth. And so that is what we're working on. If I'm going to center what we're thinking about here in Chicago, we are moving to task shifting mental health care models that really do center a non-clinical workforce. As you had shared, Rob, our team has developed an intervention that takes a public health approach to mental health care. We've trained over 700 non-clinical Spanish-speaking frontline staff who are in these high-capacity emergency shelters. And they are reducing the number of people that may ultimately need care. And so, one, going back to what do we need to do, I do think we need to think about how to build a workforce. To Rebecca's point, who is this going to be? How are we going to support it? Who are we going to bill? How do we get them access to training? We need to coordinate what that training is going to look like, and then continue to advocate for more, just more billing, more supplies, more funds to think about specialized care. Maybe the last thing I'll say is mental health providers on the ground, as well as advocates, need to be informed about what this panel is speaking about, because we need to understand how we can work with clients in this context with a changing landscape like this. There's a lot of work we need to do.
For sure. I know that at MindSite News, one of the things that we're trying to do is build out our capacity to report on, we've been doing this in Chicago, reporting on immigrant mental health issues there. And we are trying very hard to build out our capacity to do that nationally. And even we know that journalists that are reporting on some of these issues are under a lot of huge amount of stress themselves, and that it can, to report on the stories of other people's trauma and the way that those traumas are told and experienced, that itself, creates some secondary trauma. So we're working to build up sort of a national network of, journalists and build in supports for those folks to be able to report on these issues and in a trauma-informed and supported kind of way.
It's an important idea, and I do think that as we think about building a workforce of clinical and non-clinical providers, how to sustain the workforce is going to be a key part of building a comprehensive mental health care system, because the realities of what you shared, secondary traumatic stress, burnout, are real realities of this work. And yet, to create healthier communities, we have to be much more comprehensive and really think about that continuum of care.
And you mentioned it too, Aimee, as you were talking, and I saw a question in the chat both about, utilizing that peer system or engaging. And so I think that's one key, not necessarily like letter of the law on parity, but the concept, that people are able to work at the top of their license, that you're engaging, a set of individuals with lived experience. And so, having those CPT codes that we have around peers, but then being able to really utilize them and pay them at the levels in which, make sense for their big contribution and expansion of the workforce that they can bring. We're not quite there yet, and need to continue to advocate around that.
Sure. Tim, I see you.
Just very, very quickly add on peers. The peer support's a huge priority for Mental Health America. And I actually think we're likely to see some sort of expansion in peer support in this next Congress, because Republicans and Democrats both really do like peer support. And it's every meeting I go to, I talk to Republicans about peer support. They really buy into it. So I do think we can see expansion of peer support during this Congress.
Great. Luke, you want to jump in on this question?
Yeah, I think generally speaking, I mean, I agree with Tim's point about, the expansion of peer support services. I think we're also seeing a lot of states really take it up in a much better way than we've seen. I think there are some concerns as far as how we take it up and making sure that we are sticking to the, keeping the integrity of peer support services and peer, the model of peer support. generally speaking, I think, as we move into a lot of different settings that are more clinical in nature and haven't always been the best environments for peers to work in. I think one concern is really seeing that peer role drift that often happens. So really looking at, one of the things that we've been focusing on at the Alliance is, how to ensure that the culture shift that is often necessary to allow peers to be as successful as they are when they are providing the services does occur within these organizations or settings that peers haven't been in for as long as some of the outpatient services or more community-based organizations that do provide peer support on an ongoing basis. But when we're getting into ERs or for those who are moving into the criminal justice settings and then other clinical-based settings, making sure that we are still sticking to the principles of peer support, that we have supervision that allows peers to provide supervision to peers like CMS has urged or sent out letters around to the Medicaid directors to let them know that that is possible and we can bill for that as well. So those are the type of things that we really are looking at to improve as a way as we expand the peer support pipeline and the peer support workforce, making sure that we adhere to those models and the principles there.
Yeah, and
Great.
I was reading the questions, if you don't mind if I just tag on real quick. One of the things that was talked about in the questions is the paradigm of parity being, insurance focused, and not necessarily as quality focused. And so, that's obviously only one aspect of what you brought up. You brought up a lot of cultural issues and other things, but I think just keeping the quality standard too and focusing on measurement-based care and quality outcomes, just becomes incredibly critical. The parity legislation itself, may not define that as specifically, but I think, most of us who work in policy in the field feel like you have to say the word quality, or measurement based in front of, when you're thinking about care, because it's just really important to have that evidence-based intervention. So I just wanted to mention that because that was just a small part of your point, but was one also that was milling in the Q&A.
Rebecca, I think that's a super important point. And as we look to the future and we try to frame the conversation that's happening, particularly in a Congress that may be a little less interested in, let's say, peer support, though they'll probably be with that. Where I think they can go is with not so much with the term parity, but with the term accountability. And I think if we begin to talk more about accountability in the mental health care system and the expectation, not only that people will get evidence-based practices, but that outcomes will improve and that you will see people getting the care that matters. We haven't, I feel like as a field, we haven't done that enough. We've talked a lot more about access and about quality and accountability. And I do think there's an important opportunity here to shift the dialogue that way.
And as we haven't gotten a chance to
Real
mention,
quick, Rebecca, and then we gotta move on to the next topic.
okay, we haven't got a chance to mention, but with the Alignment for Progress and the Kennedy Forum, we did roll out a set of North Star goals for the movement of 90% of people screened. And the reason I'm bringing it up is 90% getting evidence-based treatments and 90% moving towards recovery by 2033. And I think that word evidence was like so important in that second 90. So I'll leave it at that.
Okay, thanks. So we've all been, reminded and shocked in recent years by the use of police force deployed against people in the throes of a mental health crisis, sometimes with fatal consequences. We know that every year over the past decade or so, around 1,000 people are killed by police, and on average, about 200 of them are people in mental health crisis. I think these are not, the best. These are the statistics that the Washington Post has developed. We've actually been doing a lot of data analysis on non-fatal use of force in cities, and we'll be publishing a big story based on data from a couple dozen cities soon. But this problem is a significant one. It's it's one of the great inequities of our mental health care system and our crisis response system. And it has led to the outrage over these killings has led to demonstrations, and to policy pushes to create mobile crisis services that aren't led by police or in some cases don't involve them at all. Luke, I want to turn to you on this. How are you viewing this area? What's the need? And maybe talk a little bit in your state of New York. There's a task force that's looking at this issue, and there's a bill pending called Daniel's Law in the New York legislature. Maybe start by reminding us about Daniel Prude, who that law is named after, and who he was.
Yeah, thank you. So Daniel Prude was a Black man who was in Rochester in March of 2020 and was experiencing mental health and substance use crisis. Went to the hospital, was quickly released, and ended up running around the streets of Rochester in the snow, naked, and had the police called as to respond to him. And instead of supporting him and giving him the needed help that they should have given him, the police put a spit hood over him, held him on the ground for far too long, and he ended up dying and was pronounced that the death was caused by the police by the coroner later on. So one of the toughest things about this is the city of Rochester really kept this under wraps for a number of months, and then when it was discovered and the body cam footage came out, the city really went into an outrage as expected. It's also good to note that this is still in 2020 when George Floyd protests were happening, and there was a real reckoning on police accountability, really, when you think about it. So what we saw in New York was really the group in Rochester getting together to create reform, but that expanded through the entire state. So we all really got behind the group in Rochester who really started this out. A bunch of advocates and local folks who really knew the community well. And this transformed into the push for Daniel's Law legislation, which would change the way that we respond to mental health crisis calls that don't involve violence or an active weapon. So instead of police being the first responders to these types of calls where police aren't necessary, it would be an EMT and a peer to go. It's very similar to the Cahoots model out in Eugene, Oregon, which has been in operation since the 80s and has been incredibly successful. And we've been pushing for this for the last couple of years and eventually got a task force in 2022 to look at how we can expand this throughout the state and really start it up. We are hopeful that this task force will be releasing their report early. As of the last meeting, I think they're working out some of the final bits of their report and recommendations to the state's governor and the legislature. So we're really excited about that. One thing I will say is that DOJ's work within this field has been incredible for us because we've not only seen them tie this to Olmstead decision and the ADA violations of the ADA as discrimination against people with disabilities, specifically mental health disabilities, but they've come crack down on police departments in Minneapolis, as well as most recently Louisville, to really say that if police should not be the first responder to calls where police aren't required to be there, aren't really necessary, and so they've instituted, mobile crisis teams, other alternative responses that have really given us more weight to what we're calling for to show that DOJ is also pushing for these things in a number of cities as a way to rectify these violations of the Americans with Disabilities Act.
And how worried are you about, essentially the withdrawal of that hammer that has been hanging over some cities under a new Department of Justice, and that, I don't think anyone thinks that, the new Trump DOJ is going to be aggressively pursuing the kind of pattern and practice investigations that the previous DOJ did.
Yeah, I mean, I'm really just not sure yet because the rhetoric coming out from Trump over the last 2 years has made it seem very much like talking about things like giving police more immunity makes it seem like there could be a negative swing. But like a lot of the other issues that we've talked about here today, we really won't know until we actually see some of what this new administration puts in place. We are very thankful to folks like Assistant Attorney General Clark over the last couple of years, who's really pushed to accelerate a lot of this. But we just kind of have to wait and see. And it also means that a lot of this is still going to fall back on the states, which is where a lot of it will end up needing to be anyway, because of the way that police are regulated, but making sure that each state, puts in a system similar to what we're pushing for in New York is going to be critical, and that's going to need that sort of groundswell action within each of those states.
Great. Well, that's a perfect segue to the next kind of area that I wanted to talk about. This New York task force is a really good example of what can happen in a state. And I think another one is efforts to address youth mental health and that crisis. A place where urgent action is needed at the state level, especially with federal COVID-linked support for school mental health coming to an end. So as the federal government pulls back and the states take on more in the realm of mental health policy, where do folks see some good opportunities? Let's talk about youth, but maybe there are other areas as well. Tom, is that something you'd like to get into? You got to unmute.
Yeah, I can say a bit about it. I mean, again, I tend to think about who's going to pay for it. That's a way to begin to think about it. And this is a place where there's an enormous increase in philanthropy. I mean, Steve and Connie Ballmer have put something like $450 million into school mental health in Oregon alone. So you're seeing enormous interest in philanthropy filling in a gap there. States are doing a lot, and it's both blue and red states. It's really interesting to see how this issue really covers the map. The one that I know best is, of course, California, where I live, and there's specifically on the youth mental health crisis. The state government put $4.7 billion into an initiative that does about 10 different things, but I think in the most innovative way, it starts very early with dyadic care for new families and providing support for new families in a way that we haven't seen in many other places. It has a virtual platform for school students. It has a new way of linking pediatricians to specialty care. But most of all, I think where it's really been interesting is it's created a different focus for youth mental health by defining schools as the place where this takes place and helping to link schools to Medicaid, which is pretty interesting. Other states have done some of this. I don't think anyone's done it quite at the scale that's intended here. And of course, important to note that California recognized right away that you don't want to ask more of the schools than what they're already doing. So it requires a whole new workforce, and developing that workforce from local communities has been a really interesting challenge. But it's a big project, lots of different arms to it. But it is interesting to see that there are states that are doing some really exciting work. And I think that will continue over the next administration, no matter what happens in Washington.
And we're participated in what we call the National Governors Association last year under leadership of Tom Murphy, and then very closely working with Governor Cox of Utah. So it was a bipartisan initiative focused on youth mental health, and came out with a report around what governors can do to move youth mental health forward. MHA and the Kennedy Forum have like a deeper report with a lot of policy work around youth mental health that we've put out around that. So again, just building basically on what Tom is saying, because there has been some models out there, particularly in the schools, and there is a body of nonpartisan, work put out by both the National Governors Association and us, like with specifically what states can do and what governors can do.
And maybe just adding to that, we're seeing the narrative go even younger, before school, that there's growing conversation around the importance of infant early childhood mental health and thinking about mental health in that birth to 5 space. And in Illinois, Governor Pritzker actually established a new state agency that unifies all early childhood supports under one umbrella. It's our division, Department of Early Childhood. And so it is a recognition that early development matters. We're thinking about ensuring that there are supports to promote emotional as well as general health and well-being. That is mental health for very young children for the very beginning, so that they can meet that trajectory of lifelong health, development, and learning. And it's exciting to see other states recognize that critical prenatal birth to 5 period as well.
Absolutely.
Isn't it great? I mean, it's there's a lot of innovation going on locally, and so and I mentioned California, but Illinois is extraordinary. Oklahoma, very interesting place to follow. Utah, of course. They're probably Texas is doing some great stuff. There are probably 10, 12, 13 states that are really doing, I think, novel attempts at trying to address this crisis. So it's going to be an interesting period. I don't think that's going to be interrupted very much. In fact, that may get supercharged when you realize that it's only going to be the states that are innovating.
Rebecca, you referred earlier to the 90-90-90 by 2033 that many of us have sort of gotten into our heads because it's such a catchy little phrase there, obviously by design. How is that going? Maybe just say, a brief, summary of that idea and where you think you're at. We are running a little behind time, so I'll try to accelerate things from as we continue on.
Yeah, I'll keep that brief then. I already explained what the 90-90-90 is: prevention, evidence-based intervention, and recovery. And so we worked with KPMG on a tool to be able to measure that. So that's on our website. So we do have a measurement base for the three. We're still fine tuning it. Measurement in this space is, as all of us know, very difficult. The data availability, and actually, I'll definitely give a nod to Tom and his book, because we used that in the beginning to like really start to frame out how we were going to measure and how we were thinking about the 90s. And so Tom and I were in lots of conversations going up into that launch of that 90-90-90. We as a community, like the Kennedy Forum, can only do so much. We recognize like we can have a convening role, a catalyst role, a policy role, and it's up to probably everybody on this webinar that I don't know who's on, to make sure that you're saying this is how I can contribute into that. And as we're, I mean, again, it's screening, evidence-based intervention, recovery. So it's really like, and it's meant to be social determinants as well, because you can't recover if you don't have housing, if you don't have food. So it's really that full continuum. And so hopefully all of us can see ourselves in, moving towards those outcomes, and really just as a movement and a North Star for that. It's not a Kennedy Forum, thing. It's really a community-wide, field-wide goal.
Great. Okay. All right. Moving on to, and we've been talking a little bit about the unpredictability of the future. So moving on to an area of great unpredictability is RFK Jr. and the potential new Health and Human Services Secretary, and what, if he's leading the nation's health services, where might things go? And I guess I'm thinking about the impact on addiction services. Obviously, he is passionate about addressing addiction, about psychedelics, and also about the availability and coverage for psychiatric medications that he may not be so enthused about. So I don't know who wants to handle that hot potato, but I'd love to hear some thoughts.
I'll jump in a little bit here, Rob, as a recovering public servant, having run one of the agencies in HHS for 13 years. It does matter who's in HHS, who the secretary is. And there already are some questions about CDC and SAMHSA. And generally, it's the secretary who will figure out who's going to run SAMHSA, who's going to run most of the health agencies. So you've already heard names for CDC and FDA. I haven't heard a name for SAMHSA. It will be interesting to know. There's obviously a nominee for NIH who ends up the head of NIMH. I don't know. It will be interesting to see. Look, I'm not 100% convinced that RFK Jr. will be confirmed. I think he's a bit of a wild card, and to be crass, I think that the president-elect has gotten what he wanted from him. I don't know that there's a lot to keep him in the game, but maybe we'll see. It does. I do think it's an issue when you have somebody who comes in with a very narrow agenda, and particularly when that agenda has been so infused by the kind of misinformation, disinformation, which in some ways has been the largest challenge to public health in the last 4 or 5 years. So that's a problem. And the way it plays out is in who that person selects for running the agencies, because the leadership of the agencies does in fact matter. And that's a real concern. I worked with Dave Weldon, CDC nominee, when he was a member of Congress, and it didn't go well. He was somebody who was absolutely committed to the idea that vaccines caused autism. And no matter how much data we could demonstrate to him that there was just not a shred of scientific evidence, it really didn't matter. This was more a matter of dogma and faith, and I think also a commitment to some of his donors. So I worry. I worry that, for instance, the director of NIMH is the head of the Interagency Autism Coordinating Committee. It would be a real problem if a director is selected based on how they view autism and that part of the job, and not on what their commitment is to people with serious mental illness, or how they envision making progress on our understanding of treatments that matter. So it's an issue, actually, not only because of their focus, but because of what happens around them, and how agencies then begin to lose the people who do care about those issues because they don't feel supported. So we could be looking at a moment when some of the best people will be leaving government. And as a former public servant, I can tell you there are some spectacularly good, dedicated people in those agencies who you do not want to lose. And it will take a long time to rebuild if those agencies begin to fall apart. So I'm concerned about that part.
Yeah, for sure. One of the things, another, again, it's always difficult to see how the rhetoric of a campaign translates into reality. And but during the campaign, Trump pledged to bring back mental institutions, to get deranged, quote unquote, people off the streets. And there is a debate, I think, brewing, that has been brewing even aside from that, over the role of mandated treatment, and to what extent do you need to, obviously there are people that are severely severely mentally ill on the street, and we need to address their needs, but what is the mechanism to do that? Luke, this is something I think you've thought about a lot from the patient's rights point of view, and I love to hear from you on that.
Yeah, I will try to keep this as brief as possible because I could talk for days about this. But I think the first thing to say is it is very concerning, the ideas of bringing back institutions as the big sort of push. And the unfortunate thing is this has been a genuine trend from both sides of the aisle, and in states, and a little bit so much on less so on the federal government. But I think there has been this attempt to find quick fixes for a growing mental health crisis, and I think a lot of people see hospitalization and institutionalization as that quick fix without really thinking about what happens afterwards. And I think that aspect, the lack of sort of consideration of how people return to their communities and how people effectively transition back into their lives has been a really massive concern for us. And a lot of the proposed legislation and policies that have been coming up, both from the federal government, but also in a lot of states, including my own in New York here, where we're seeing a lot of pushes for involuntary removal from the streets to hospitals, without a lot of effort being placed into getting folks housing afterwards, or a lot of the same sort of rhetoric being placed around that. And then when we talk about more forced treatment, I think it also speaks to this lack of quality service provision from our end. The fact that people even get to a place that you are considering forcing them into treatment instead of offering them voluntary services that they want to take is also incredibly concerning, because what we know and what we have seen is oftentimes people say no to services not because they don't want support or help, but because what you're offering them doesn't fit for them, or you're trying to throw something at them that they're not really looking for right now. If someone's looking for housing, but you're trying to medicate them first and foremost, it's not going to work. They're not going to be listening to you. They want housing, so we should deal with the housing aspect first and then talk to them about what else they might need. But we often see with a lot of these pushes, it's more of this idea that this will be the silver bullet, and that's just not the case. The mental health system is a continuum, and people do swing through that, but making sure that, if we are going to be bringing more beds on, which once again, I think that, we are not effectively utilizing the beds that we do have, because of that lack of proper transitional support when people are leaving these beds to get back into the community. And I think that the rhetoric coming out of the Trump campaign is concerning, because if we're talking about just institutionalizing people, where is the money going to go when we need it for transitioning people out of the hospitals, when we need it to help keep people in their communities? If we're focusing purely on institutionalizing people, which is one of the most expensive areas of the mental health system, then we're not spending anywhere near enough money on those community supports or that transition back in the community that help keep people happy and healthy in their communities, and things like working and having the lives that they're looking for and really hoping for.
Are there any particular initiatives that are happening? I think of things like peer respites, and we've done some reporting on that. I'm not clear about what the growth of peer respites has been. I think there has been some. These are places, for those who don't know, where people who are experiencing a mental health crisis or think they may be entering a mental health crisis can go. It's not clinical. It's sort of a comfortable place, supported place where they can be for a period of days or a week or two. What's happened is that an important element of kind of what you're talking about, Luke, and
Yeah.
or things like
Yeah,
that?
I think definitely having more alternatives to hospitalization for a lot of folks who aren't as comfortable with that. Also having alternative programs, thinking of, not just pure respites, but, crisis stabilization centers that we have brought up in New York and a lot of other states are looking at as well. Also considering peer programs that do effectively engage people who might be harder to engage, or might have we have struggled as a system to engage as well. Things like the INSET, the Intensive and Sustained Engagement Team program that New York has really begun to expand, and we're really thankful to see that, because they're engaging people who otherwise would be sent for court orders. And we're seeing that people do want services and do engage in services, depending on how you actually, bring them those services and how you engage with people. That's the real critical part. So we're seeing those alternatives pop up more and more, and we want more funding for those kinds of programs, and not having as much funding coming from the federal government to do some of this is going to hinder some of the expansion, because it's going to require states to invest a lot of money into these by themselves without that additional funding from the federal government.
Rob, I think, I don't want to be the skunk at the picnic here, but I do think this is a this is a tough area. And, I think we all need to recognize that a lot of times the headlines and the policies are driven by the 2 or 3% or 5% of people who you just won't accept services, don't want them and need them terribly. And I say this because I think, to go back to your original question, I'm not sure that anybody's arguing for asylums, but we need capacity. We need the places that help people with a really bad form of psychosis in which they don't think they're sick, where they can be someplace safe. And we haven't done a good job of that. And I think what Luke's talking about is great in terms of providing that kind of diversity of services and lots of choices for people. But one of those choices has to be having beds. And we don't have them in most places, particularly for anyone under the age of 18. It's really tough. So we had it in the past. There was a time when we actually, I think, did a better job of ensuring that people were safe. But that we're not there now. And I do think it's not going to be a federal issue. You're not going to see this coming from the White House or Congress, but states will need to step up. And as you know, in California, we've got Prop 1, which is now passed into the Behavioral Health Services Act. And part of that will put a huge bond forward to build back beds and to actually have the capacity that we haven't had.
So, on that point, one of the questions that's come in, and I'd like to turn to some of them now from our viewers, is speaking to whether there is apt to be changes in the IMD restriction that keeps, that limits federal funding of mental health units to being no larger than 16 beds. What is, I don't know, Tom or someone else want to speak to?
Tim and I have talked about this a little bit.
Yeah.
I don't know what the state of play. This has been in the conversation for 2 decades because 1963 or 65 rule that has never made sense. Tim or Rebecca, what's your read on the likelihood that gets repealed?
So the likelihood of a full IMD exclusion repeal, which as Dr. Insel just mentioned, prohibits institutions with more than 16 beds for patients aged 21 to 64 receiving Medicaid funding. The idea that the prospects of that entirely being repealed are zero. That's not going to happen because there's a huge price tag associated with it that always scares people away whenever the last time there was a serious attempt to even consider it was about 10 years ago. And the price tag was quite high and immediately shelved. But you might see some additional. There are waivers to the IMD exclusion that states can file for. There's 3 of them. I won't get into the specifics, but and those are used to some extent. That have limited. States are allowed to provide stays in an IMD. We might see some expansion of that, but probably maybe more on the substance use disorder side. But I don't imagine it's in the cards that we're going to see a much of a fundamental overhaul to the IMD exclusion or how that works.
Tim, what about care within the criminal justice system, the Medicaid support pre-release? Is that likely to continue?
I don't know that it would be likely, but I do say that's something that I think we're seeing a relaxation of that. You've got, of course, all the suspending Medicaid rather than, and that's a state issue, is to suspend Medicaid rather than terminate it when someone is in jail or prison. But providing, allowing Medicaid to reimburse in a jail or prison setting, I do think there's more of an appetite for that. Although I don't know how far. I don't know what we're going to see in Congress based around that, at least in this coming Congress.
And just to be clear on that, for our audience, CMS has allowed states to submit waivers that allow states to begin to enroll people in Medicaid while people are still incarcerated, when they're about to be released, and to provide treatment. So that could be reversed under a new administration, or the Biden administration has granted those waivers to, I don't know how many states, a few. Thoughts?
I mean, anything's possible, but I don't think that's going to be a target for being overturned and stopped. But again, as we've seen in the last 36 hours, anything's possible with the income. But
right.
I don't think that's going to be in the crosshairs to say.
Okay, I'm going to throw a couple, some more quick questions from our audience. For work requirements, states that impose, or if the federal government imposes work requirements for Medicaid, would people determined to be disabled and on Social Security or disability be exempt from the work requirements? Tim?
But I think the way it's played out with the 13 states, I mean, everyone is slightly different, but for the most part, yes, if you're disabled and you have SSDI, yeah, you're going to be exempt from those work requirements. It's generally for able-bodied adults in between 18 and 49, generally speaking. Sometimes a little bit beyond 49, but yeah, for the most part, I think that if you're receiving Social Security disability income, you would be exempted from that.
Okay. Here's another question. Besides delivery of services and care, what is the outlook for NIH and NIMH budgets and/or ARPA-H? Will there be a call to action for private philanthropy to fill the gaps if those don't? I assume those are alternatives to each other. Like if those budgets shrink, will private philanthropy fill the gaps? Or yeah, thoughts?
Yeah, I can say a little bit about that. In the first Trump administration, he proposed an 18% cut to NIH. And we used to always joke that the president's budget was meaningless, and it always was, basically, because in that same year, Congress gave the NIH about a 6% increase. So it really depends on the two appropriations committees, the committee in the House and the Senate. That's where the budget comes from. And those members have continued to support NIH through all of these years. In fact, when I was there running the NIMH during the Obama years, they were pretty lean for us. We actually didn't do so well as the NIH has done since. So I would say you really want to look at who's on the committees and where they're focused. I do think there is likely to be some discussion about reorganization, and somebody's likely to ask the question, does NIH really need 27 institutes and centers, or is there some more efficient way to run a large research organization? There'll be some things like that I think probably need to be discussed.
Sounds like you think maybe maybe the answer is yes to that question.
Harold Varmus recommended that they be consolidated to 6 institutes back in 1998 or 1999, whenever that was. At the end of the Clinton years, that never happened, and they've just continued to expand. But I think there's, as I said at the beginning, I think there's a need for disruption and for thinking about new ways to do things. ARPA-H, by the way, partly grew out of a frustration that it was so difficult to change NIH. And so ARPA-H is this new advanced research product agency for health that's supposed to do mostly moonshots on healthcare issues. They've been well funded. I think that their future really depends on how Congress looks at their first couple of years and whether the team can convince Congress that they've got enough moonshots that they've funded to warrant continuation. But there certainly will be a moment here where I think members of Congress are going to be looking at all of the different health agencies and asking who's really having an impact and what's really worth continuing.
Okay.
And
Another
Rob,
question here is, what role can litigation play in responding to changes in mental health policy across the country? Anybody want to jump on that one?
Yeah, I think litigation has been a really strong factor in advancing alternative supports and also, reducing the trampling of rights for a lot of folks. I think of a litigation out in Alameda where you see a lot of additional services being rolled out by the county because of litigation. I think sometimes even the threat of litigation can often change the way certain areas will provide services. But it's also just a very helpful thing as an advocate to see the outcomes of litigation and what sort of courts see as reasonable changes to be made to systems that aren't working for folks often. So that's one major aspect of it. And then also really just helping to see what the legal rights for folks are when it comes to litigation as well.
I was just going to bring up Witt versus United too, as a major case in the field. And so I really think it was able to, and largely through like the CEO Alliance and the work of a lot of the advocacy groups, we were able to really elevate like what's the real message there and what's the importance of it. At the same time, the courts were, running through the process. And so I think it can be a really important piece.
Although I would also say that it's been 10 years since Witt versus UVH was filed, and we still don't have any finality to that litigation. So it's certainly not a source of rapid resolution of these issues, but
Sure.
it does, I guess, stimulate change, even if the final ruling is justice delayed.
Well, Rob, I would note too that California and Illinois essentially codified the WIT standard into
Right.
their statute. So then those are big states. So that's a big deal. And Oregon and to a lesser extent Georgia had a slightly lower standard, but it is, and I know Kennedy Forum has a model bill that would codify the WIT standard. So I do think that I don't think any of that happens without WIT. So you have,
Right.
a huge state like California passing this monumental law because of litigation. So litigation can spur other things as well.
And we
Okay.
sponsored that bill in California with Steinberg Institute. So
Right.
Right.
Another question, interesting question. Consumers have been disheartened, concerned, and troubled about recent headlines involving Acadia and residential treatment center abuses. We have also read about many mental health, substance use disorder treatment facilities not using evidence-based care, and yet the entire parity paradigm focuses solely on plans and insurers' role in consumer access to services. How do you see quality access being incorporated in parity?
that was the one I was reading when I jumped in and said, the evidence base is like critical in quality care. And so it may not be, it has to be a piece of the puzzle. Parity may not solve for all of that. And there's other, pieces that really, and so I'm not in any conversation in the mental health community where we don't talk about quality and evidence base and how to also make sure the policies are in place, for those things to move forward. So I'm sure others have comments on that, but
Yeah, and I would chime in. We strongly support, I mean, quality is important, accountability is important. We were all shocked when we saw the Acadia story. And of course, you had the substance use disorder patient brokering that was all over the news 7, 8 years ago. That being said, the parity law itself is an anti-discrimination law. We shouldn't forget that. It's an anti-discrimination law, and I don't think you want to merge the law itself with a separate but very important concept of quality. So I just do want to refocus. The Mental Health Parity and Addiction Equity Act is an anti-discrimination law. So let's not forget that patients and individuals are being discriminated in their insurance coverage for decades. And so the law was designed to stop that discrimination. So I don't think we should take an anti-discrimination law and extend that to something that's not intended for. That being said, quality is incredibly important. And also in substance use disorder care, making sure that access to medication-assisted treatment is there, which a lot of facilities still don't have. That's important. So I think quality is incredibly important. But the parity law is an anti-discrimination law.
And just Tim on this, I think we just need to remember, as Patrick Kennedy said, when the thing was passed, at the end of the day, it's going to require litigation, but it most of all requires enforcement. And that's what we've been missing. But we're seeing that now. So California has this massive enforcement case earlier this year, largest ever by our Department of Healthcare Services. There are a bunch of others that'll be happening. A Department of Labor here at the federal level has really stepped up to talk about this. So I do think that while the federal government does have a great role here in enforcement and regulation, it may now come to the states to have to step up and do some of the same things. And that's going to require advocacy.
All right. Well, we have about 5 minutes left in our scheduled time. So maybe we can do a lightning round of the panel. And folks, I'd love to hear from you. Something you feel good about, optimistic about as we enter 2025, and what are things that we all can be doing to support mental health in our communities. And Aimee, I'll just go on the order of the tic-tac-toe board on the Zoom here and start with you.
Maybe continuing the conversations around innovation and really thinking about what states can do in this time. I think that public-private partnerships have always shown opportunities to be innovative and creative. A lot of what we see in terms of innovation sometimes starts with private foundation dollars that then grow into something more significant. So I'm hopeful for those partnerships to continue, really strong leadership, and really thinking about comprehensive ways of caring for one another in community.
Thank you. Tom?
Yeah, I think one of the things that's changed in the last decade, and especially in the last 2 or 3 years, just increasing public awareness of this as an issue. In the years I was at NIMH, I always felt like I was sort of the caboose. Like nobody ever really paid much attention to mental health. It was always around infectious diseases, cardiology, and cancer. That's not true so much now. There's really is a public awareness that this is the issue of our time, particularly for young people, that we're risking the loss of a generation to mental health challenges. And so people realize we're going to have to focus on this, and we're going to have to do better going forward. And I think that's just a long overdue, vital conversation to have.
Great. Tim?
Yeah, I'll just build on what Tom just said. I do think that, I mean, I've only been in the advocacy space for 10 years, and just since I started, it's dramatic, the difference between how much you see elected officials actually want to do something about mental health. And mental health, not just, but 7, 8 years ago, you walk into a room with a member of Congress or a state legislator, they say, well, mental health's one thing. I'm interested in opioids. I want to do something about the opioid. Now you see these two concepts are merged together. And in the youth mental health crisis, no one has to be convinced that it exists. And every elected official, every member of Congress I meet with wants to do something. That what are the solutions going to be? That's up for debate. But there's no lack of will or desire to do something about it. And I think it's up to everyone. Everyone is an advocate if they want to be, to advocate that we do need to do something, we do need to follow through, and we need to follow through with funding as well, in addition to the good intentions.
Great. Luke?
Yeah, I think I'm most excited about sort of innovation and collaboration. I think the push for more states to really focus in on their systems and find ways for these systems to work together and not so much of a siloed fashion, including down to the local providers really working together to ensure that people are getting the services that they are desire and really need, but making sure that no one's really falling through the cracks. I think while this time can be a little nerve-wracking, I think it does also foster a lot more collaboration between organizations, whether it's because of finances or because of just pure need. So I'm really excited to see what we can do with that more collaboration and work together there.
Okay, and Rebecca, you get the last word.
Thank you. Well, I'll build on a little bit of also what Tom and a lot of others were saying, but, I think the time is still now. I don't think the administration change has shifted that. I think we've been, as a collective community, working for a long time to build everybody's in it together, companies, even insurance company, we all need to move for this to change. And so looking for those opportunities to really double down on systems change and to make sure that we're leveraging both the opportunities or the opportunities that we have together, I think is just the critical piece of that.
Great. All right. Well, thank you. Thank you all. This has been really interesting conversation. I think we could obviously with this group and with these issues, we could go on for another hour easily, but we will spare our viewers that. And I'll just say that, if you appreciate the kind of information that we shared today, I hope you'll check out MindSite News if you haven't already and sign up for our newsletter. And of course, if you're thinking about making some end of year donations, you got about 11 days left of the year. and we will happily receive your donations. We're in a fundraising period, so every dollar we get gets doubled, gets matched because of our membership in the Institute for Nonprofit News and the News Match program. And we would love to continue engaging with you. We'll be doing more events like this in the future. So, signing up for our mailing list will not only get you the MindSite Daily News in your inbox, it'll also get you information about upcoming events. So thank you again, everyone, and on the panel, and thanks to the audience for joining us.
Yeah, and
Thank you.
thanks for your
Thank
critical
you,
role,
guys.
Hindsight News.
Thank
Thank you, Rob.
Thank you all.